Good morning, everybody. Today we're going to finish the PowerPoint and the information related to menopause, um, osteoporosis, endometriosis, uterine fibroids, and erectile dysfunction. But before I did that, I wanted to go over the information that what I presented very confusingly yesterday. The other thing is there was a ask about the readings. The readings were posted in Blackboard and they were visible in the 125p course in Blackboard. So the readings were posted and they are there. So for your reading enjoyment. Okay, I modified the slide and this is what I will replace in Blackboard. So to review or start over related to hormone replacement therapy, there's estrogen, there's progestin, and then there's combinations. And again, that decision is a decision based with the provider and the client based on many things. Most often, the estrogen progesterone combination is desired, is what's ordered. Um, and it does relieve the symptoms of menopause. But as you know, there's an increased risk of heart attack, stroke, breast cancer, dementia, and blood clots. There needs to be a conversation with the provider, with the client about family history and self history related to any of these things, and then a decision. And some of it is whether or not the patient is going to be on the medication, and also for how long. So the risks are higher for these things for women who are continue the medication greater than 60 years old, while those between 50 and 59 had a slightly decreased adverse cardiovascular event. So it is a little confusing. There's a lot of variables. And again, it is a conversation with the client and the provider with risks and benefits depending on how they feel and all of that. Some clients may decide to take estrogen alone, um, but there's not an increase in breast cancer or heart attack with that. The combination also has less risk of osteoporosis fracture. So you can see how the medication is going to be tailored based on the client's um, history. Okay, so then we're going to move on into erectile dysfunction. So erectile dysfunction increases with age, but it can occur at any age. And many men are affected in the United States. You're welcome. It can be transient or chronic. It's associated mostly, with age. It increases with age, and it is a cardiovascular issue. So things like atherosclerosis can play a role. Diabetes, as you know, as it progresses. Um, you have those vascular changes. So those with diabetes are at risk. Kidney disease, those with stroke, smoking, and hypertension, those all cause those microvascular changes in the vasculature, which can lead to erectile dysfunction. Also, it may be medication related. So going back to the conversation that we had at some point, whatever, when a provider orders a medication, they think the client is taking it, right? So we have to have, or there needs to be a conversation with the client about if they're not going to take the medication, that they need to communicate that with the provider. And there's a variety of reasons why a client may not take it. And one is they don't like it, or there's side effects, or it's too expensive, or, can you think of any other reasons why somebody wouldn't take a medication? Side effects, cost. Oh, taste. I didn't think about that, Stephen. Depression, forgetful. You have other life worries, not concerned with health. And sometimes the clients need to understand the lifelong consequences of not taking a medication with something like hypertension, because we know that with hypertension, if you don't take your medicine for a couple of days, you don't see the difference. Polypharmacy, they forget to take which one. Absolutely. So there's a bunch of reasons. So erectile dysfunction can be linked with or common with diuretics, thiazines, SSRIs, TCAs, which are psych meds, and beta and alpha blockers, which are given for hypertension, and some cardio, what's the word? Chronotropic. They're medications that can control heart rate. So when these medications are prescribed, I mean, these are significant medications given for significant issues. And as with any medication, we need to communicate with the client that they need to, take it, when to take it, and all of that. And then as well, if they're not going to take it, to communicate with the provider as soon as possible. So consider someone with erectile dysfunction, the alteration in body image, self-concept, and self-esteem can be traumatizing. And so, yeah, they're not going to take those medications that are causing the issues. So one of the medications that might be prescribed is Viagra or sildenafil, which I love seeing these commercials with either my children or my parents, which is, wonderful. But the way the medication works is smooth muscle in the corpora cavernosa, and it increases blood flow into the penis. It does not cause an erection, but it enhances it. It's effective for about 70%, so it's not effective for everybody. The onset is about an hour. The duration of the effect is about 4 hours. What kind of side effects do you know about this medication? I do not know things look blue. Somebody needs to put their, where,
Professor,
yes.
I'm having a hard time logging into Blackboard Collaborate this morning. I had to call in, but there's a couple people in my group that also are having a hard time logging in to Collaborate also.
I don't have an answer for you.
Oh, okay. I'll just stay
Yeah,
on the phone.
I was able to log. I don't have an answer, and I don't have a fix for that. And for that, I'm sorry. I would just say to keep trying.
Okay, I will. All right, thank you. Sorry.
Okay, so side effects. Can someone please explain to me about blue? No? Okay. So side effects. I saw someone listed dizzy. Hold on, let me look back in the chat. I got distracted. Everything has a blue tone. I don't know that, Julia. Did you see that in the reading? Oh, okay. All right. Okay, side effects. Headache, dizziness, flushing, rash, and nasal congestion. What is the most serious side effect associated with this medication? Yes, hypertension. So it can cause significant hypertension. And what medication is contraindicated with this medication? And what are nitrates used for? Yeah, so they're specifically used for angina. So, the nitroglycerin pills that people take is a common thought about a nitrate. So because that lowers the blood pressure and improves blood flow. It is a vasodilator. That's why somebody who has angina with the vasodilation, it improves blood flow to the heart muscle. But if you're taking nitrates, and if you were to take this medication on top of it, you would have significant hypertension that can cause a heart attack or sudden death. So again, having a conversation with the client, making sure that we know all of the medications that the client's on so that the provider can make a decision over whether or not this is an appropriate medication for the client. What kind of teaching should, besides the nitrates, should we talk to a patient about this medication? There's a couple that are significant. So we're going to talk to them about the incidence of priapism, which we're going to talk about in a minute. But what about taking it? There's 2 dietary considerations that are pretty big. Dietary considerations. So one is to avoid taking it with meals, especially with a high-fat meal, because it decreases the absorption. And yes, Stephanie, thank you. The other is to avoid grapefruit juice. What does grapefruit juice do to this medication? Because we've talked about grapefruit juice since September. When we were, or actually,
well, they're both. Oh, sorry. Well, grapefruit juice interacts with a lot of medications because they're vying for the same pathway. Usually, it's the CYP450. So they're both trying to get through this door at the same time. If you can think of it that way, I guess. And so it interacts with Viagra and it lessens its efficacy.
It actually increases the plasma concentration of this medication.
All right, sorry. Sometimes, yeah, it goes either way. Sorry about that.
Yep. Yeah, so it can increase the plasma concentration of this medication. So again, we need to have a conversation with the client about how they're taking the medication. What type of client is this medication contraindicated for? Should be pretty easy guesses based on the conversation we've already had.
Heart disease?
Yeah, so people with heart disease, such as a recent heart attack, someone who takes nitrates, absolutely. Stroke, dysrhythmias. And then your book talks about anatomic deformities of the aorta. So any kind of cardiac issues, this medication may not be prescribed for. Somebody had their hand up. Samantha, did you have your hand up?
I did a little while ago, but it was simply to tell you that there were people trying to get into the group, but it was a while ago.
Okay. No, I just got a notification of somebody. Okay, well then I'm moving on. Okay, so one of the danger side effects of this medication is extended an erection longer than 6 hours. I know of 4 hours, but your book talks about 6 hours, and it can cause significant tissue damage. So a client needs to be instructed that if this occurs, they need to seek help and go to the emergency room because there's medications that can be given. There's also other medications that are on the market now. One is Cialis or Tadalafil. That's why they call it Cialis, because it's easier. It does have a faster onset. It lasts a little bit longer, but the side effects are similar. So that's the beauty of talking about medications in prototypes, because these medications work the same. the effect or the duration might be a little bit different, but the side effects are the same. So anyways. All right, so we're going to talk now about some application for some of the information that we've talked about yesterday and today. And the first person we're going to talk about lives in the neighborhood, and her name is Mary Martin. Mary is 75 years old, and she lives with her son, her daughter-in-law, Helen, and the rest of the family. So Mary is, she is very sassy, by the way. She's recently widowed. She moved in with Gil's family. She's a wee bit of a busybody and a little bit bossy. She moves into their family after the death of her husband, and she has a very good relationship she moved in with her son after the death of her husband. She has a very good relationship with her son. She does not have a spectacular relationship with her daughter-in-law. She doesn't see very well. She's got cataracts and glaucoma. So again, she's having difficulty managing her house. And so her son says, come and live with us for a little while. She's on a medication used for her glaucoma. That's the only medication that she's on, and they're eye drops. And she doesn't really like them, and she thinks they're too expensive. She does have a car and a driver's license, but she doesn't drive very much because, as you know, people with cataracts and glaucoma, night vision can be very difficult. They can see halos with the street lights. She goes to the neighborhood senior center, and what type of assessment related to osteoporosis do you think, because she's 75 years old, would be important to assess this client for at the senior center? I see a lot of mobility. I see diet and nutrition, and that could be a concern, especially for somebody who had some financial challenges at their house. And also, let me see if it's on here. I see a lot of nutrition, mobility, falls. What kind of exercise is she doing? Great, because we would want to make sure that she's doing what?
Exercising.
What kind of exercise?
Weight-bearing exercise.
Right, it's the weight-bearing exercise. So yoga, but maybe we want to make sure that it's not that extreme yoga, that she's doing extreme stretching or twisting, so that to prevent fractures. And I'm hoping like it's yoga at the senior center, so that they know that and they can lead that, and she's not doing yoga maybe with 20, 30-year-olds that have more flexibility. Let me see. So a height and weight, and also see how she's trending. So as Ann noted, looking for a height loss, absolutely. Bone density screening. I don't know how often they're done, Stephanie. I don't know if it's annual. I don't think so, but she should have at least one done for a contrast and to look at against the normal findings. What about a vision assessment? Because she's got cataracts and she's got glaucoma. So she needs a vision assessment, and whether or not she needs glasses or something like that. And consider the impact of her vision on her ability to cook as well. And she was a wee bit of I'll say hoarder. So consider her safety in her home prior to when she went to live with her son, and her ability to walk around. I am working with a friend whose mom house, for some reason, loves the QBC, and spends a lot of time ordering things and things that she really doesn't need. And the house is kind of full of packages and boxes, and there's a safety concern. Let me see. All right, let's see how we did. So a home assessment, either where she came from, if she's still there, or the home with her son, as far as safety. Lighting is important. Diet history. So not only what she's eating now, but if this is someone who had poor calcium intake, would be important. Medications by the provider they may do calcium supplements, vitamin D supplements. There's an extent that will work. Present diet, activity, and then support systems. Can anybody think of anything else? Okay. Next question. Hold on one second. Okay. Mary seeks medical care for a bacterial vaginal infection. Which change should the nurse consider as a possible explanation in a menopausal or postmenopausal client? Increased vaginal lubrication can result in more bacteria harbored in the vagina. As the vaginal pH increases, bacterial infections can be more common. Night sweats can lead to more bacteria. Hold on, I got to put the poll up. Hold on. D, thickened tissue, vaginal tissues tear more easily. All right, there you go. Okay. Thank you for the positive affirmation for the sound effects. Somebody had their hand up. I don't have a notification for whose hand. Oh, wait a minute. Now I do. I found it. Nope, that's my hand. Okay. So let me show you the responses. So the majority of you are aware or chose B, which is as the pH rises, bacterial infections can become more common. A postmenopausal woman, A is incorrect because it's decreased vaginal lubrication. And you can have bacteria related to the fragility of the tissue. So it absolutely can happen, but it's not because of increased vaginal lubrication. Night sweats don't lead to more bacteria. It leads to not sleeping and being really uncomfortable. And D is incorrect because the vaginal tissue is thin. And again, you can get like irritation related to the thinning tissue, but the D is incorrect because it is not thickened vaginal tissue. Anybody have any questions about that? Okay. Update. Clear. Oh, I'm going to clear. All right. Next question. Mary's, oh no, this is the questions. Okay, next question. We're up to $2,000. No, that was the $2,000 question. I'm so sorry. My slide got out of order. Okay. We're going to talk about the next patient, and we're going to talk about talking with your patient about sexuality, which can be difficult and maybe a little bit awkward, but it gets easier over time. And this is not for you this week in clinical by any shape or form, but it is depending on the specialty area that you work. It needs to be part of the conversations that we have with our clients, especially when we're talking about continued medication or continuing whatever treatment regime is there. And there should be and needs to be an open conversation with the healthcare providers, with the clients, so that they know that they can have conversations with us. So we're going to talk about Greg. Greg and Benito live in an upscale single-story home in the North Woods. They have a nice yard. They live close to town in the neighborhood. There's a fitness center where Benito works out, and there's a golf course located nearby, hiking trails. So they live in a better area of the neighborhood where there's more resources and those kinds of things, which is going to come into play in a moment. So one of the ways of talking to a client about their sexuality is using the Plicit model. And as you go through your career and work in different areas, you're going to develop knowledge and skills about things like treatment and medication so that you can provide that education to your client, because you have that information, or you're going to look up that information just as much as you're talking to your clients now about when they go for a test, right? And you're talking to them about what the test is going to be and where they're going to go. It's the same body of knowledge that you're going to develop as you go through. So the Plicit model, all of these letters at the bottom, the P stands for permission. So the P is really to make sure that your client has permission to be able to talk to you about issues related to sexuality. We don't have to have all the answers, but we can find the person that does, or we can refer the client to the provider, something like that. But we need to make sure that the client knows that they can talk to us about these issues. And it's going to come into play again with the case study that we're going to talk about. L is limited information. So these first two steps in the Plicit model are related to the limited knowledge and information that we have. And then again, if you're a cardiac nurse or a cardiac rehab nurse, or you're a neuro nurse, you're going to have more information about that specialty area, and you're going to be able to provide more information and guidance to the client and the family. So L is limited information. So you're going to be able to know about the medications and provide that information to the clients and the families. The last two sections or steps, the specific suggestions or intensive therapy, are more for more seasoned nurses that have more information and more knowledge and more skill related to sexuality. And they're going to be able to provide specific suggestions or provide intensive therapy. So again, that's not us. That is not the entry-level nurse, but it's someone who's gone through more training and has more experience. Okay, so we're going to talk about Greg. Greg wandered into the health fair this week in the neighborhood as he was passing by, and he stops at the blood pressure screening table and is shocked to learn that his blood pressure is 138/94. The nurse at this screening writes his blood pressure measurement down and suggests that he has it checked again in a week or so and follow up with his primary care provider if it remains elevated, right? And we know blood pressure, our patients don't know that it's elevated unless it's significant, and then they may have headaches or something like that. So he elects not to mention his elevated blood pressure to his partner, and he's sure that, like any good partner would tell him to go get more exercise and eat a healthier diet, and probably to go to the doctor. He stops by the pharmacy and gets his blood pressure taken by the automatic blood pressure result, and it's still elevated, 134 over 90. But he decides that his blood pressure is probably not that bad after all. What do we think about the accuracy of those blood pressure machines at the pharmacies?
They're not always 100% accurate.
I'm not very fond of them. I really don't like them. I mean, I guess if you're going to do nothing, it's better. But let's talk about what you already know, the size of the cuff. It's one size, right? So you're not going to have an accurate result because the size of the cuff may not be correct. Okay. But it is a screening tool, and I would think if it's elevated, it probably is elevated. But you should be able, or the client should know, whatever the result is, there should be some communication with the provider. One of the things that we've done as an NSNA group is we've done blood pressure clinics, and I have little wallet cards that we give to the people that we do their blood pressure so that they can have those cards and then take them to the provider, because nobody remembers what those numbers are, right? But if you write them down, if you can put it in their wallet, or they can put it in their wallet, then they'll have it when they go to the provider the next time. So consider that. Okay. So he sees a nurse practitioner and about his elevated blood pressure, and is prescribed Inderal 20 milligrams each day. So I'm going to give you about 3 minutes to look up this medication and consider whether or not this medication can affect sexuality and what we would tell Greg. So you've got till 10:05. Google or your med book. Very fast, Ryan. Thank you, Alexandria. Okay, so as people have found out, this medication can cause erectile dysfunction. It doesn't mean that it's going to for every client, but it needs to be part of the conversation when this medication is prescribed, that if there's any kind of change, that the client needs to notify the provider, because then they can change the medication. Inderal is a very common medication that's used for hypertension. So again, a conversation with the client, because as our story continues, shortly after, he notices a change in sexual function, and the situation creates distress for the client as well as in the relationship with his partner. He was taking the blood pressure medication for several weeks, and as a follow-up, the nurse practitioner, his blood pressure is a little bit better, 136 over 88. When asked if he's experienced any problems with the medication, he says he doesn't think so. In reality, he's uncomfortable, mentioning that his erections have not felt the same, and he decides that the symptoms are probably related to the fact that he's overtired. See how we can blame them on something else, and as well, if we don't have that open conversation with the client, they may not mention it. So as the nurse, how could the nurse have interacted with this client differently? So I see provide information about the prescribed med. The nurse can bring it up. She could have proactively brought it up, mentioned side effects. And the other thing is, consider that a client may not associate the medication with the side effects, especially if they take a couple of weeks to occur. Right? So, and you could blame it on being tired or stressed. Ian is saying, these are the common side effects. If you have any of them, we can talk about them. Again, we want our patient to take the medication, or we want the hypertension to be treated. So he finally shares that with his partner that he thinks the blood pressure medication may be causing his decreased sexual response. Greg tells Ben that he quit taking the medication for a few days to see if his problem would go away. So after several weeks of not taking his medication, there's no problem. So what do you think some of the possible outcomes of this decision could be? You know this. And what are the risks, though, of hypertension? So yeah, so stroke, absolutely. Heart attack. Also consider that progressive hypertension can lead to more vascular changes, which can make this problem worse as well. And no, he shouldn't have stopped taking the medication, and it was preferred that he would have continued to collaborated with the provider, that he stopped taking the medication. Okay. It shouldn't have a rebound effect, not taking the medication. It's just going to be it's going to have hypertension. Okay. So he does talk to his provider about stop taking the medication and explaining why. The nurse asks in a very matter-of-fact way if he's experiencing problems having an erection. Again, that's part of the implicit model. The client finds that the no-nonsense approach a relief, and his anxiety about talking about this is significantly reduced, and he confirms that it's a problem. He's told that it's a side effect, and it can happen. It's kind of bummy that he found out afterwards, though, right? And look at his blood pressure, 148/96. Probably a little bit of anxiety. And the nurse practitioner explains that having blood pressure this high is not acceptable, but also that not being able to have an erection is also not acceptable. We don't want our clients to be unhappy or experiencing side effects of medications that are not desirable. And so they need a different treatment plan. We talked about this. Okay. Like any good client, decides or tries to, what's the word? Negotiate that maybe just avoiding sodium in his diet and increasing exercise can fix his hypertension. With a blood pressure that high, probably not likely. So now the new medication prescribed changed is lisinopril, 5 milligrams. So again, I'm going to give you about 3 minutes. What do you think about this medication associated with hypertension and in conjunction with erectile dysfunction? Okay, so as people are seeing, this medication has a far less incidence of erectile dysfunction, which may be one of the reasons why this medication is prescribed. So again, having an open conversation with the client about side effects can be very preemptive, and opening that conversation so that a client can come and talk to a provider about sexual issues is important. Okay. So we are up to $4,000. Hold on one second. A 58-year-old with erectile dysfunction tells the nurse he's interested in sildenafil. Which action should the nurse take first? Don't put your answers. I'm going to put the poll up. Discuss the common adverse effects of erectogenic drugs is A. B. Assure the client that ED is common with aging. C. Tell the client that sildenafil does not always work for ED. D. Ask about any prescription drugs that they are taking. Okay. Ryan, did you have a question?
Nope, I missed it again. Sorry, itchy trigger finger.
Okay. All right. Hold on one second. Okay. I forgot the theme music. Okay, so vote for your choice. All right, vote in the chat. I'm very disappointed today. Yeah, so we need to see what type of medication that the client is taking, because it could be a very easy fix for lack of, a better word, but it could be a very easy fix because of a review of the medication, and maybe a medication can be changed like it was for Greg. The problem could go away. The other thing is we need to know what type of medications the client is on, because we need to make sure that the client's not on those nitrates, right? So we do need to have a medication review. Okay. All right, it is 10:14. I'm going to take a break until 10:25. Okie dokie. So the next thing that we're going to do is talk about Helen Martin with a focus on menopause and osteoporosis as well, considering that. So Helen from the conversation that we had about Mary. She is 48 years old. She works as a bank teller, so a sedentary position. She's married to Gil, as you know, she. You know what, Ryan? Her husband did not ask her if Helen or Mary could move in. He just said, "Mom, come on over." So Helen's not very happy. So there are very good mother-in-laws in the universe as well. So I try to be one. But we all know that there's challenges. But anyways, continuing on our story. Mary is also overweight, and she has a history of cholelithiasis. What is cholelithiasis? I just want to make sure everybody knows. Yeah, gallstones. So what kind of diet would she follow? Hopefully lower fat. So a high fat diet can cause pain and discomfort related to mucking up the gallstones and making the gallbladder work pretty hard. Okay, Great. Thank you. Okay. So she hasn't slept well this week, and honestly, she doesn't sleep very well at all. She's had a hard time falling asleep because she's worried about everything, her kids, and there's other issues related to her kids that we didn't talk about, problems at work. She's got the night sweats and feeling hot and cold, periods of irritability and moodiness. So she gets up a lot. She paces around the house. By the way, Mary's watching television and the TV's on too loud, so that's not great. So considering possible menopause, what we're going to do is break up into groups, and I want you to consider what questions the nurse should ask Helen related to menopause, and what education topics should be included, and what specific information would you include. Okay. And then add to that as well a conversation about hormone replacement therapy. So there's 3 things that you're going to work out in the group, which is questions and assessments for the nurse for Helen related to perimenopause and osteoporosis. What specific education topics should be included for her? And then a conversation about whether or not she's interested in hormone replacement therapy and what information should we get. And I am making breakout groups, and the breakout groups are going to be 20 minutes. So it is 10:30. So at 10:50, we will come back. I'm going to make sure, and I'm seeing people leave, and I'm getting very sad. You don't want me to be sad today. Please do not leave the breakout groups, because this is important information and application and will help you with the knowledge that you need as a nurse. And also, I'm going to say, for the exam. Okay. I will be coming into the groups if you have questions. Okay, everybody's back in the main room. One's reconnecting. Okay. So let's talk about Helen. So what questions I'm going to ask you to, how are we going to do this? I am going to ask one person from, do you know what group numbers you were in?
No.
Okay.
Yeah.
So that,
Yes.
oh, James knows group 6. Okay. All right. So let's talk about some basic assessment questions, initial questions that we should ask Helen. What ideas did people come up with? And this would be so much more fun if we were in a big classroom together.
Do you want us to just raise our hand, put them in the chat? What do you want us to do?
Let's do it in the chat, because I think it's a challenge with everybody trying to talk together. Where again, if we were in the big classroom, people could raise their hands, and I think if we do that here, it'll take up way too much time. So let's put it in the chat. So some people are asking about the last period. Okay. Also, how long has what been happening, Alexandria? I think you're probably talking about the sweats and the irritability. Okay, I see family history. Current medications are always important, and we need to make sure that we do that med reconciliation at every visit for a variety of reasons, including all of the ones that we talked about today. Family history of breast cancer. So that's going to be more in the next slide when we talk about the hormone replacement therapy. But we know that when we go to the doctors and they ask for, the update of information, they always ask about family history, about a variety of things. Thank you, Alexandra, for your answer. We do want to ask about diet and exercise routine. So again, if we're thinking about the osteoporosis and if we're considering obesity, we do need to have a conversation about what kind of diet she takes, whether or not she's on a special diet. She says that she controls her cholelithiasis with her diet. And I'd really like to know more information about that. Like, what does she do to help control that? Anna, I don't know what SART is. We need to know about her menstrual history, pregnancies, childbirths, dyspareunia, drug or alcohol use. Absolutely. What makes sweats and irritability better or worse? I mean, she does have some stressors that are that can be causing the irritability, as well as we've talked about, the sweats and the hot and the cold can really interfere with sleep, and which is really critical to functioning during the daytime and not being crabby. Sleep hygiene, going back to the lecture that we had last semester about all the things that people can do to promote sleep. So things like, noise in the house. And we talked about how her lovely mother-in-law is watching TV at night and maybe keeping her awake. Also, the other stressors. Michael, I am talking. I hope people can. Okay. All right. Phew, I was a little worried. Okay. Thank you, Renee. Thank you, Christina. Okay. So what type of screenings would be important to know if she's had done or maybe should be in the queue to be done? Bone density? Absolutely. LFTs considering her cholelithiasis? Labs for hormone levels? What type of cancer screenings, Ryan? Pap smear? Absolutely. Bone density, pap smear, vitamin D, calcium levels. A thyroid test probably maybe because of the obesity, but I want to focus more on the topics for today, but it absolutely might be one of the conversations. Mammogram, absolutely. And I think all of this kind of rolls into the fact that we need to find out whether or not she has an OBGYN provider and whether or not she is compliant with the recommended visits. And just because she has an OBGYN provider doesn't mean that she goes every year or as ordered or as recommended, right? We need to know about past surgeries, mental health resources, because yes, she's having some irritability and anxiety, and there's definitely some family issues, but the hormones run amok related to menopause, and that can cause an increased anxiety as well. And it can compound the anxiety issues. At what age should a woman start seeing an OB/GYN? I would even say maybe even earlier than 18. It depends on whether or not there's sexual activity. And that would be a conversation with the provider. Okay, so let's talk about screening some more. Well, the hard part too is having a, I'm going to call them a child, but the sexual activity, those appointments, how are those made and how is that information given to the young person in order to be able to go, and having that conversation with an adult to facilitate that process. There's a lot of components there. Okay, let's still talk about health screening related to Miss Helen. There's more. You absolutely can have other GYN issues not related to sexual activity. Absolutely. We talked yesterday about fibroids. You can have fibroids and cysts that can, or endometriosis that can cause problems that need treatment. Absolutely. What about blood pressure? I didn't see anybody say blood pressure. Again, vital signs are so important that teach us, can give us a lot of information that's going to lead us to further questions that we should be assessing for. And again, going back to diet. Any other screenings? Any other questions? Okay, so what specific topics, not just the topics, but what specific information should we be giving to Helen? So, for example, for exercise, we need to have a conversation with her about weight bearing activity. How much exercise? How often? Managing stress, dressing in layers. Yeah, we need to do an assessment about what her current knowledge of menopause is. What her current knowledge of menopause is, as well as what her knowledge of her body and what her body may be going through related to menopause. Perineal care, avoiding infection, managing stress, avoiding caffeine, smoking, alcohol. So Thomas has calcium and vitamin D intake. So what are we going? So we need to assess that. So consider that she says she controls her cholelithiasis with diet. And we talked yesterday that one of the things that people often do when they want to reduce weight is they knock out the entire dairy component. So we need to have a conversation with her about what her calcium intake has been over a lifetime, but also what are calcium sources. And many of them are calcium sources are higher in fat. So having a conversation with her about calcium sources like milk, but low fat milk. She probably should have a vitamin D level done. So we would anticipate that blood level may be done. And also then interpretation of that and giving her information about vitamin D sources, including being outside in the sun. So we need to look at the lab work, as Nicole said. Phytoestrogen foods such as what? We talked about those yesterday. Soy. There's several listed in your book. Brown rice is one as well. And again, that's a low fat food, high fiber. So it fits checks a lot of boxes. Any other topics that we should include for this client? Stress reduction techniques. weight-bearing activities. Okay, so hormone replacement therapies. So what information do we want to derive from the client so that she can make her decision about whether or not hormone replacement therapy is appropriate? So we need to make sure she doesn't have any cardiovascular issues. So I'm going to go back to the blood pressure. So the blood pressure is important, and we need to know what her blood pressure has been, where she's trending, right? Does she have a history of hypertension? So family and personal history of breast cancer. So Julia, I want you to be more specific about benefits and risks too. But what other information should we be, how uncomfortable she is, how it's affecting her daily life? Is she at high risk for a DVT? Again, she's got that sedentary lifestyle with her job. So she needs to offset that with increased activity during the day, but it's also going to help us with that weight bearing activity and warding off osteoporosis. Yep, maybe this might be somebody who maybe their lunchtime they take walks, right? So that weight bearing activity is going to increase perfusion or maintain perfusion to the bone. So it's going to help us have healthier bones. So an increased risk of breast cancer, we need to make sure that we do a family history. Why compression socks, Thomas? Oh, to prevent the DVTs, to prevent venous return. I'd also want to know whether or not is she sitting most of the day or is she standing most of the day with being a bank teller. Yeah, and especially if she starts on hormone replacement therapy, I'd want to know whether or not she has any edema. So yeah, it helps with circulation, it helps prevent venous stasis, it helps prevent edema. If she's sitting, we want to have a conversation with her about not crossing her legs because of that compression. Did you know that the effects of estrogen can be enhanced if combined with ginseng? So we need to have a conversation. That is trivia, not an exam question, but we need to have a conversation with a client about them taking, doing a dietary intake as well. What else? I think it would be important to ask to find out from the client and have an idea, though it's not an exact answer, an idea of how long her symptoms have happened. She could be on the tail end of an approaching postmenopause. She could be, or maybe it just started and she's miserable and very uncomfortable and affecting her ADLs. But what if she's on the tail end and maybe, we don't need this intervention? Libby, I don't know if the past use of birth control can cause any issues. I don't know that answer. I know that the longer that you're on birth control, you do have a risk of DVTs. I know that you shouldn't, smoking is a concern because of, the associated risk factors and consequences. But I don't know that. Yeah, absolutely. I did read that too about estrogen increases cholesterol and bile, and it can increase the chance of gallstones. And it could cause more problems for her. Um, the story does continue, which we're not going to talk about today, but the story does continue that she ends up being pretty symptomatic related to the gallstones and ends up having her gallbladder out. Okay, so the last client that we're going to talk about is, we did this. Okay, the last client we're going to talk about with a focus on sildenafil and erectile dysfunction. So we've got Danilo Ocampo. And for those of you that have come to simulation already for the second time, Daniello is married to Lydia. Daniello is a 74-year-old retired pathologist, and he comes to the healthcare provider asking about possibly taking sildenafil. His medical history includes hypertension, a heart attack, and angina. And he takes lisinopril every day, and he has nitroglycerin, 1 tablet sublingually as needed for chest pain. Oh, and it's the same slide. Okay, so what do we think about? I had questions. What do we think about what information we should have from Daniello? What questions should the nurse ask? What questions should the nurse ask? So it is absolutely contraindicated. So we do want to know how long ago he had the MI. Does he use the nitroglycerin often? There are people who, never use it, and then there's people who pop 4 or 5 a day, which scare me. But I think that, yeah, Stephanie, I think we need to have a bigger conversation and using the Plisset model to have a conversation with the client about the experiences related to erectile dysfunction. How long, sorry, I'm getting pop-ups for emails. How long it's been a problem? Is it recent? Is it associated with this medication? Like maybe he just started on this medication and now ED is a problem. Okay. So that, again, who's prescribing these medications, collaboration, interprofessional collaboration with the provider, all providers of medications, so that we can have a conversation. He does have a history of hypertension and the myocardial infarction and the chest pain. So all of those make it that this medication is probably not appropriate for this patient, but we do need to delve in further about the incidence of erectile dysfunction because maybe that can be helped. All right, any questions for me? Because I am done. We have visited most of the neighborhood today, but I hope that it was helpful having patients with real information and real histories that we could apply the information that we learned over the past couple of days. As far as when should hormone therapy be started, as far as a patient who's perimenopausal? Is that what you were asking, Tessimone? So that's going to be an individualized conversation with the provider and the client. And it's going to be a conversation about the symptomatology, how much it's bothered. And it's when the patient is bothered by the symptomatology that it should be started. So again, we're talking about somebody who's going through, I'm going to say regular menopause versus somebody who's going through surgical menopause. That's that young person who has their ovaries removed. That person is going to start on hormone therapy, probably. Okay, again, an individualized decision, but the provider is going to talk to the client about the risks and benefits, and there's significant risks related to osteoporosis for somebody who has surgical menopause at a very young age. But if we're talking about somebody who's going through, I'm going to say aging, menopause, that is going to be a conversation with the client, and it's really symptom relief. It does not have to be started. It's really symptom relief. And again, it'll be for a period of time. It's not forever. And then the provider is going to have a plan for about how long. You're welcome. I'm going to post the PowerPoint that I post. Let me start over. The reason why I do not post the entire PowerPoint with all of my questions and all of that kind of thing is because my goal is to have people in class listen and pay attention, and I like surprises, but also it increases the involvement if the information isn't just on the PowerPoint, right? And so I will be posting not this entire PowerPoint, but I will be adding some of these slides. You're welcome.